So hello to everyone. We are back with the new EasyChem chat. And I have the pleasure to welcome Jesper Kjaergaard, who is, I think he's in vacation now from Copenhagen. Hi, Jesper. Thanks for accepting our invitation. Hi. So I have to congratulate you and, of course, the entire group of the Box trial because you get 2 publications in England the same day. That's wonderful. So congratulations first. So this is what we are talking about. Management of cardiac arrest patients. The first question would be about blood pressure. Can you explain to our audience how you came out with the 2 levels of blood pressure that were the 2 interventional arms?
That part of the intervention probably needs a bit of explaining because we aim to and actually managed to have a double-blinded blood pressure target intervention for this trial. And what we did in practice is taking the blood pressure modules that every one of us use in the intensive care unit and offset these modules. All of them come with the adjustment knob electronically in the module that can be manipulated. So each of the modules were offset by 10%, either to show more blood pressure than was actually in the patient or to show 10% less blood pressure than was actually in the patient. And the investigators didn't know whether the offset was higher or lower than the actual blood pressure. And therefore, we managed to keep a double-blinded blood pressure target intervention with a separation of 20%. And that was exciting to us. We've done a few validation studies, of course, to be sure that this was a safe method. And we think it is, and we applied that to all of the 800 patients that were included in the trial.
Great. So the point would be how you translate the results of this study, because when you just look, the main results, we don't find difference in neurological outcome in the 2 groups. So people could say, should we just choose a level, one of the 2? Should we be between the 2 levels? How you do translate this in clinical practice?
Yeah. If you read the results of the trials very strictly, I think you can choose whatever blood target of the 2 you want. But in our opinion, the results actually favor going for the lower blood pressure target. That would be 63 millimeters of mercury, and we aim to do that and have implemented that in our clinical practice for a number of reasons. One is that the only method we have to achieve a higher blood pressure is to administer more vasopressors, primarily noradrenaline. And there's been no trials suggesting that vasopressors or catecholamines are beneficial to any patient. Of course, they are necessary to maintain perfusion pressure, but they are probably having a lot of side effects and potential complications to the patient. So in our opinion, if aiming higher does not translate into a clinical benefit, staying low is what you should do. So that is our opinion and translation of the results, and therefore also alluded right away to how we manage this in clinical practice.
Now, I have a specific question because I didn't mention you are intensivist, but also cardiologist. So I presume that also having lower blood pressure would be, of course, beneficial for the heart. You know that I'm a brain lawyer. So, of course, we want to raise blood pressure for the injured brain. So the question would be, in your study, you have a lot of cardiac causes with incredibly high survival rates. Can you think that this could translate in all cardiac arrest patients? For example, in hospital cardiac arrest or non-cardiac causes? Would the result can you translate the results, or should we think differently?
I think the in-hospital cardiac arrest population could be targeted in a similar trial such as this. I think the reasons for cardiac arrest and the level of and burden of comorbidity in these patients gives me some hesitations towards extrapolating the results of the Box trial to these patients. We did include patients with non-shockable rhythm in out-of-hospital cardiac arrest setting as well, and of course so I think the results could be transferred to this patients group as well, but they represent a minority, and they do so in very many of our out-of-hospital cardiac arrest patients. So I think to be safe, these results pertain to patients resuscitated from shockable rhythm out of hospital cardiac arrest. In my opinion, and I think that that's a very interesting part of your question. So when we discuss with our neurointensivist colleagues, they aim for much higher blood pressures than we do in traumatic brain injury or even stroke patients. And of course, we are looking at dealing with hypoxic brain injury in these patients, and that's the majority of reasons for patients not surviving the cardiac arrest when they hit the intensive care unit. So I definitely think that the blood pressure target should be what is beneficial for the brain. And this was exactly why we thought that would be interesting, because being a cardiologist, I want to have as little afterload for the heart as possible. So we actually had a dilemma: should we target a higher blood pressure, supposedly beneficial for the brain, on the expense of the cardiac function, or wouldn't it matter? And that was the very reason for conducting this trial. Of course, you can argue that we should have gone even higher in blood pressure targets, and I guess a number of investigators out there would argue that we didn't aim high enough to see a benefit, but we still think the results are pretty valid. There is very little to gain from aiming higher.
I understand. So you mentioned the hypoxic brain injury, and I want now to move to the next point, which is, of course, oxygen management, which is also very relevant for the hypoxic injury. So again, the other part of the box trial was testing two different levels of oxygen targets, let's say kind of permissive mild hypoxemia, while we have a kind of normal values. These are around 68 to some 70 something, whatever. Again, the question is, does PO2 is not relevant when you work in that ranges, or you still think that PO2 could be still a matter when you work outside the ranges that have been studied in that box trial?
Yeah. The reason we went for PO2 is, of course, again, being a cardiologist, that PO2 and oxygen administration have been quite extensively studied in myocardial infarction, which is a great percentage or fraction of hospital cardiac arrest. So we wanted to be sure that when we target lower FiO2s, PaO2s in these patients, for the sake of the heart, we wouldn't do any damage to the brain. So that was the limits, and we chose the targets because the targets that we should aim for in cardiac arrest are defined pretty wide. So we have a low limit for hypoxia, and we have a quite high limit for hypoxia. So we basically managed targeting the lower limits and the higher limits, and that was the reason for the choice of these two groups, to stay within guidelines but still kind of tease out if there was a benefit.
So again, if people now want to translate the results of the box trial to clinical practice, in mind your trial, they have in mind the coma care from Helsinki, which is normoxia versus permissive hyperoxia. And then they have, of course, the subgroup analysis of ICU ROCs. Can you tell us how you combine all these two trials together and give a message, practical message to the audience?
Yeah. Well, our message from the box trial remains that less is more. like we see no benefit of targeting a higher blood pressure. There are no statistical significant differences in any of the subgroups that we studied. The primary endpoint and the secondary endpoints were neutral as well. But if you scrutinize the data both in the blood pressure and the oxygen intervention, the point estimates all are in favor of the lower targets. So in our practice, we still aim for the lower levels. And that, of course, coincides very conveniently with being a cardiologist and having lower oxygen levels for our myocardial infarction patients.
Okay, I have a very last question. In the area of precision medicine, where people think we can individualize care, do you think as a clinician that in the future we can do a study where the oxygen and the blood pressure levels are based on a monitoring system rather than a fixed values compared to what is standard of care? Or you think that we should remain pragmatic and work as we did at the moment with, fixed target in 2 patient population?
Yeah, it's a fantastic question. I've had similar questions on how to individualize blood pressure and oxygen targets in these patients. And I actually think it's so interesting that we should seriously consider doing trials in this area. I'm not sure how to do it. So the design of this trial is going to be complicated, and I really hope that we can have discussions in the near future of all the other investigators in this field of how to approach this target, because personalized medicine, individualized targets in these patients must be the way to move forward in this area. I think we've done so many trials now that are neutral on big groups. We need to target smaller groups to see if there is any benefits at all.
So thanks again for being with us, for the very precious comments about your study, and congratulate the entire group that has provided this great work for our critical care field. See you next time.
Thank you.